In this video we will explore the anatomy of male internal genital organs, a series of glands associated with the spermatic ducts and located at the crossroads of the urinary and spermatic ducts, the prostate, the seminal glands and the bulbourethral glands. The tests, epididymis and ductus deferens, will be covered in a later chapter. Starting by the prostate, we will begin with an introduction providing its major role in the processes of fertilization and maturation. Following that, we will focus on the descriptive anatomy of the prostate as a fixed conical gland under the base of the bladder, enumerating its different supports that constitute its extrinsic anatomical relations. Next, we will take a closer look at the diversified structure of the prostate made of fibrous, muscular and glandular tissues that constitute its intrinsic relations. We will, then, proceed to describe the blood and nerve supply and lymph drainage of the prostate. The prostate is a glandular organ, unique and central at the crossroads of the urinary and spermatic tracts. It is situated at the midline beneath the bladder and above the urogenital diaphragm and penetrated by the proximal part of the urethra. Thus, the prostate has a major role in fertilization and maturation. It is accessible through rectal examination. The prostate is located at the anterior part of the pelvic cavity between, forwards, the pubic symphysis, backwards, the rectum, upwards, the bladder, downwards, the superior fascia of urogenital diaphragm and laterally the sides of the funnel of levator ani muscle. The prostate has the shape of an inverted rounded cone, just like a chestnut, with an upper larger base and a lower blunt apex. Its long axis is oblique forwards and downwards. The prostate has four faces: anterior, posterior and two inferolateral. Its consistency at the rectal examination is firm, and its surface is regular. The prostate is whitish-gray colored. The dimensions of the prostate are age-dependent. It is normally broader than it is long, like the cecum. The prostate is 4 cm wide, 3 cm high and 2 cm thick. It weighs 20 grams. The prostate is a highly fixed organ with supports at each part of it. The base is fixed through the fusion with the internal urethral sphincter at the neck of the bladder and the perforation by the urethra which traverses the whole length of the gland. The apex is cradled between the levator ani muscles. The anterior surface is connected to the bodies of the pubic bones by the puboprostatic ligaments. The inferolateral surfaces are clasped by the levator prostate parts of levator ani. The posterior surface is fixed by the penetration of ejaculatory ducts at the prostatic slits of the base and prostate's own ducts. The true capsule surrounds the periphery of the gland. The prostatic plexus strengthens the true capsule laterally. The false capsule is a condensation of pelvic fascia, continuous, in front, with the puboprostatic ligaments, and the prevesical fascia, backwards, with the rectovesical fascia of Denonvillers which attaches to the perineal body, laterally, with the sacrorectogenitopubic fascia, downwards, with the superior fascia of urogenital diaphragm, and, upwards, with a thin septum separating the base of the prostate from the base of the bladder. The false capsule contains the urethral sphincter, particularly the arched fibers of the urethroprostatic muscle surrounding the anterior and lateral surfaces of the apex of prostate. To perform its function, the prostate has a sophisticated architecture and a diversified structure, which we will dissect from the periphery to the center. The true capsule is a thick white layer of connective tissue at the periphery of the gland. The fibromuscular stroma is a mixture of connective tissue and smooth muscle disposed into strands linking the true capsule to the verumontanum and separating the glandular acini. The prostatic glands are 30 to 50 tubule-alveolar glands opened into the prostatic urethra by 15 to 30 prostatic ducts arranged into 5 glandular lobes: anterior, middle, posterior and 2 lateral. Usually, there is no clear distinction between them. Schematically, the anterior lobe is small in front of the urethra and is, mainly, made of stroma. The middle lobe stands between the ejaculatory ducts and the proximal urethra and is much important. The posterior and lateral lobes form the right and left lobes of the prostate. The prostatic utricle is an embryonic remnant that takes the form of a half-centimeter deep pouch opened in the verumontanum between the ejaculatory ducts, resulting from union of the caudal ends of the paramesonephric Mullerian ducts, homologue of the uterus. The ejaculatory ducts run obliquely alongside the prostatic utricle from the prostatic slits at the base to their openings in the verumontanum of the prostatic urethra. The prostatic ducts open on the urethral crest and in the sulcus on each side of the prostatic urethra. The study of the zonal anatomy of McNeil is essential to the study of the clinical anatomy of the prostate, with the aim of establishing a topographical classification of its pathology and thus guiding the procedures that will help in its diagnosis. The zonal anatomy of McNeil is a rather histological verumontanum-based description. The anterior zone consists, exclusively, of fibromuscular stroma. The peripheral zone represents 70% of the weight of the prostate, circles the prostatic urethra under the level of the verumontanum and extends backwards and upwards. The central zone represents 25% of the weight of the prostate, lies behind the prostatic urethra at the level of the verumontanum, circles the ejaculatory ducts and has a seminal vesicle-like histology. The transition zone consists of two lobes circling the prostatic urethra at the level of verumontanum. It extends laterally and upwards under the neck of bladder. The main arterial supply of the prostate is represented by the inferior vesical artery, that is a branch of the internal iliac artery through its prostatic branch. The prostatic branch of the inferior vesical artery lies on the prostatic surface of the lateral lobes before penetrating it. The internal pudendal and middle rectal arteries give small branches to the lower part of the prostate. Sometimes, the middle rectal artery provides the major supply. The prostate is drained by the prostatic plexus between the true and false capsules. It flows into the vesicoprostatic plexus situated at the front and sides of the groove between bladder and prostate and drains backwards into the internal iliac veins through internal pudendal veins. The lymphatics of the prostate around it drain into the internal iliac and sacral nodes, mainly, and the external iliac nodes, accessorily. The acini receive parasympathetic cholinergic innervation from the pelvic splanchnic nerves, but this is much less important than the muscle fibers of the stroma, which contract to empty the glands during ejaculation, and which are under sympathetic adrenergic control from the inferior hypogastric plexus. Most operations for the removal of prostatic adenomata are now carried out by the transurethral route, with the resectoscope being passed along the urethra to a point proximal to the seminal colliculus, the verumontanum, so that the external urethral sphincter, which is distal to it, is not damaged during the resection. An approach through an abdominal suprapubic incision into the retropubic space gives a wide exposure of the organ. We will now move on to the anatomy of the seminal glands, otherwise known as the seminal vesicles. Starting with an introduction to the seminal vesicles, where we will define the seminal vesicle and its role, we will proceed to describe this gland as the main structure of the retrovesical space of the rectovesical septum. Afterwards, we will take a closer look at its muscular structure and enumerate its peritoneal and visceral anatomical relations. Finally, we will recall the blood supply, lymph drainage and nerve supply of the seminal vesicle, which are not different from those of the prostate. The seminal vesicle or seminal gland is a paired exocrine gland connected to the spermatic tract. It is a thin-walled elongated sac applied against the base of the bladder above the prostate. It produces about 60% of the seminal fluid and acts as a spermatozoa container between ejaculations. The seminal vesicle is applied against the retrotrigonal fossa of the bladder above the prostate. Each lies lateral to the ampulla of the ductus deferens of its own side, behind the retrovesical portion of the pelvic ureter and in front of the rectum. The seminal vesicle is a lobulated, blind-ending tube much folded on itself with a long horizontal axis when the bladder is empty and vertical when the bladder is full. Three parts can be distinguished in the seminal gland, from the top to the bottom: the tip, the body and the neck. The seminal vesicle is drained at the neck by a single duct that joins the lower end of the ampulla of the ductus deferens behind the prostate to form the ejaculatory duct. The seminal vesicle is 5 cm long, 1 cm wide and half a centimeter thick. Its length can reach 10 cm when unfolded. The wall of the seminal gland is made of 2 layers. The muscle is thin and made of inner circular layer and outer longitudinal. The mucosa is very folded with glandular appearance covered by column or pseudostratified epithelium. The seminal vesicle is applied against the retrotragonal fossa of bladder. Backwards, the rectovesical fascia covers the gland downwards and peritoneum of rectovesical pouch upwards towards the tip. Medially, it lies next to the ampulla of ductus deferens, laterally next to the vesicoprostatic plexus and pelvic fascia, on top, below the retrovesical portion of pelvic ureter and, downwards, above the prostate. The arteries of the seminal vesicle are branches from the inferior vesicle and middle rectal arteries. The veins of the seminal vesicle drain into the vesicoprostatic plexus that flows into the internal iliac vein. The lymphatics of the seminal vesicle drain into the internal and external iliac, obturator and sacral nodes. The smooth muscle of seminal vesicles receives fibers from the pelvic plexus. The sympathetic fibers run in the branch from the first lumbar ganglion and a motor. Their division produces sterility, for the paralyzed muscle cannot contract to expel the stored secretion and spermatozoa. There is no emission or ejaculation. At the end of this course, we will make a brief study of the bulbourethral glands of Cowper. The bulbourethral glands are paired rounded exocrine glands. They lie one on each side of the membranous urethra in the deep perineal pouch above or deep to the perineal membrane, on a level between the prostate upwards and the bulb of the penis downwards, and are covered by the urethral sphincter. They make a small contribution to seminal fluid. The diameter of the bulbourethral gland doesn't exceed 1 cm. Its single duct is 2.5 cm long. It runs parallel to the urethra and pierces the perineal membrane posterolateral to the urethra. They open into the bulb of the penile urethra. The gland of Cowper is a tubule-alveolar gland that has a role in the lubrication of the genital tract during copulation. The male internal genital organs are, mainly, glands connected to the genital tract that carry out ejaculation, copulation and thus fertilization through sperm production and spermatozoa storage. They are fixed pelvic organs with variable dimensions and relations.